All right, thank you. I want to make sure I'm loud enough. I'm the caboose of the afternoon, so I'll try to keep you a little bit awake. Can we turn it up just a little bit? So I didn't want to steal samples, and I didn't get a lot of great voice samples from my patients. So I'm going to be doing some acting, and I'm going to promise you it's not quite as good as the real thing, but I'll try to emulate some of the voices and try to give you a little bit of information. When it comes to dysphonia, it's really a black box for you guys. It's a little bit of a black box for us sometimes, but it's really a black box for you because they come in hoarse or raspy, and you don't know kind of what that looks like inside their larynx. And so it's hard to formulate a differential diagnosis. And as some of the articles that I included, one of the articles specifically looked at treatment patterns between otolaryngologists and primary care. And primary cares were much more likely to treat with antibiotics for dysphonia than the otolaryngologist. Now, part of that sometimes is that the timing of that treatment may coincide with a sinus infection or some other purulent productive cough and all the different things that we've talked about on here. But when we get to the otolaryngologist, we're not thinking that same way. And so there's this black box, and so I'm going to try and help you with that black box, and more importantly, try to formulate some kind of a differential here. What are the things? I have one word, hoarseness. Can I come up with any other thought processes to make this treatment of my patient more interesting? So the objectives will be first to take a targeted voice history. So getting that voice history is going to help me to maybe start to formulate a differential diagnosis. Also get an idea of how soon I need to refer this patient, or do I need to refer at all. Broaden the differential diagnosis. Can I have one more word than hoarseness to my differential diagnosis when someone, it can't always be a sinus infection, especially if they keep coming in saying, it's not draining anymore, I'm just hoarse. And then understand the current clinical practice guidelines, which I'll be honest, as I read them, it's more of a list of don't do's than a list of do's, and that's very discouraging for you. I think I'm going to try and hit maybe a couple points where I'm going to say, take this home, remember this. The first one is, believe your patient has hoarseness. So when, I'm going to give you an example. I saw a patient about 6 months ago, came in and said, I'm hoarse. And I'm listening to her talk, and I'm like, that sounds really normal to me. She says, I feel like I have to make an effort that I wasn't making before. My brother is dying of thyroid cancer, and I'm scared. I'm scared to death. And I'm like, wow, this is a little out of proportion. Maybe we have a little underlying psychiatric adjustment disorder going on here. So I thought, well, it's a scope, and I get to kind of show her everything's okay. This is an easy one. Well, I go down there, and this totally normal voice person, to me, and she has a left vocal cord paralysis. I'm going to tell you later on that they're very typical sounds that we can expect with the vocal cord paralysis, but she had no hoarseness that I could register. And so I said, wow, you actually have a finding. I don't want to get you alarmed. It probably happened when you were really young. I mean, gosh, you sound great. It must have been there for a long time that you wouldn't even have noticed it. But I have to actually get a scan of your neck and chest. So I get a CT scan of the neck and chest, and it's sad when the cuts start at the base of skull, and their first comment is about the metastasis in her cerebellum that came from her lung. So how easily could she have been missed? How easily could she have, and I don't want to scare you because now I don't want to order CT scans on every patient who comes in the door who feels a little bit pressured when they speak. But you have to listen to your patient. So what is hoarseness? It's the perception that my voice doesn't have the correct pitch, loudness, effort in making my voice. And this is a common thing they'll tell us, it's just, can't you hear it? I'm hoarse. And you're like, you sound pretty good to me. And that happens to us a lot. I know it's probably happening to you guys. So they have that perception. If that perception is there a week, no problem. But if that perception is going on for a period of time, I think we need to attend to that patient, even if it's just to allay their fears and have someone take a look. So what is the function of the larynx and the voice? First, the larynx, kind of interesting, get nerdy. Deglutition, I think, respiration is the interesting one on there. The voice box opens when we breathe in and actually closes when we breathe out. Why does it do that? Well, it keeps a positive airway pressure, all those alveoli from falling closed. It also, being able to close our voice box actually was part of the progression of us being able to be upright because it maintained our upper girdle when we would strain to pick things up. Otherwise, you'd go, as you tried to pick something up, and all the air would release, and you wouldn't have the strength. It has to do with deglutition. we like to talk and swallow through the same orifice. And so if we didn't have the larynx to cover the windpipe, we wouldn't be able to swallow. But the one we're going to talk about today is voice. And voice has three components that makes the sound that we enjoy. One is the power, the generator behind it, our lungs. It's got to force the air through that area. The vibratory source is the larynx, and the resonator is everything above that. So your lips, your tongue, your supraglottis, the back of your pharynx, your nose, all these go into voice. And if you talk to any vocal professionals, they'll start talking about their head voice and their diaphragmatic voice, and they're using different parts of that supraglottic tract to make those noises for them to feel like there's a difference. A little bit of anatomy here, if I can find the... So we have the tongue base here, we have the epiglottis, false vocal folds. These are the arytenoids. This is the postcricoid space where it enters into the upper esophagus. These are the, right in between the white and the pink is the ventricle. There's a little space in between there. These are the aryepiglottic folds, and this is the vallecula, just for a little anatomy. And then the voice box has 5 major muscle groups in it. We have the cricothyroid, which is innervated by the superior laryngeal nerve. It does also sensation in the voice box. Some is done by the recurrent, but most of it is the superior laryngeal nerve. Then we have the only opener of the voice box, the posterior cricoarytenoid. One little muscle is the only thing that can open our voice box. And if it's ever been damaged, as an ENT, we'll see that they will close in someone who has a bilateral vocal cord paralysis. Then there's the openers, and there's the closers. Lateral cricoarytenoid, the interarytenoid, and then the thyroarytenoid, which is the vocal cords have a muscle in them, and that muscle actually shortens the vocal cords, loosens them, and creates a laxity that creates the lower voices that will produce a kind of a glottal fry, like that's going to be using that muscle. So we'll get into more of that now. The voice box has the vibratory sound that it creates is based upon a theory called the myoelastic aerodynamic theory. We had to come up with something very scientific sounding, but basically it's like a wreath. The sound flows, or the air flows across it. It creates a vibration, and the vibration of the two surfaces create a noise. In order for it to vibrate, it has to have a superficial part that is very pliable. And so this is the squamous epithelium. So this is a vocal cord, and like the white area we saw before, this is going to be its medial edge, and if we were looking from above, we'd be looking down on the top edge. So this is the epithelium, and between the epithelium and the muscle underneath is several layers called lamina propria, and the superficial layer is called Ranke space, and that's where we get a lot of swelling from, let's say, tobacco use or acid reflux. The space in between the intermediate and the deep layer form the vocal ligament, which gives it a little bit more strength and is coming towards its attachment to the thyroarytenoid muscle. So this ability to be floppy, overlying the rigidity underneath, is what creates the sound. And so what happens is air flows through. And when air flows through a tight space, there's a thing called Bernoulli's principle where the pressure gets low and things want to suck together. And so this is kind of written in this direction, but if you look at it backwards, the first thing we see is air's coming through and it pulls the bottom lip together. It's actually going from backwards to forward. But it pulls the bottom lip together, and then that bottom lip will shut with the top lip, and then the air is still coming through, so it's pushing the bottom lip back open. And so it's doing it kind of in this fashion, but real fast. And so that's creating our sound. So if this cover isn't working well, we get a very specific set of sounds, and that is most of the raspy voice that we hear. If this muscle isn't bringing those into juxtaposition, then we won't get any sound, and we'll get a very breathy voice, trying very hard to get the sound out, but the sound will slip out so fast, and I'll get tired. And so they get really fatigued if that's going on. So this is a stroboscope, and this gets into our field. It's something that you wouldn't see in your office, but it's looking at the voice box and that wave that I showed you with my hands under a strobe light. And what it does is it just off-centers the strobe to the pitch, And we get the flip book effect, which is kind of like that Mickey Mouse book where you see 30 Mickeys, and if you flip the book, you can see Mickey do a little dance or something. So we get that with our video strobe, and we can see some characteristics of the voice box. We can see the mucosal wave, how wide the vocal cords pull apart, the amplitude. We can see that vertical phase I talked about. We can see the asymmetry between the two sides, and we get into some really nitpicky about this part, and it'll get a little bit more than you need to know, but that gives us a lot of information. So we have various ways of looking at the vocal cords, but you don't. And so what you need to do is come in and say, okay, you've been hoarse. What's been going on? And then they give you their history, and there's some things that you're trying to grasp at. First of all, is this really sudden onset? If it's really sudden onset, is it really severe? Or has it been really gradual and every bit of the way it's been getting a little bit worse? Are you having any pain with talking? Are you having any fatigue when you talk? Do you feel like it's just when you sing? Do you have a hard time in just the high pitches or when you're singing softly? Do you notice any effort that you feel like, I sound the same to everybody, but I feel like I'm really pushing harder than I used to push? And that alone can be a reason to refer them. Do you get short of breath with speech? Some other things we want to know about that deglutition and the other aspects. Do you get any problems swallowing? Do you get any heartburn? Are you having any cough? Certainly cough is quite traumatic, and as we'll learn later, heartburn can be quite traumatic too. Big things are hard to miss. Do you have stridor? And do you have laryngospasm? Do you wake up in the middle of the night choking and wondering why you're choking, and after a while of breathing it seems to go away? And then do you feel like there's something always stuck there? So these are parts of the targeted history. They're going to help us. The practical guidelines really wanted to focus on you guys, on is there a history? Did you miss like a big chunk of history that says, oh, this is obviously related to that? Were you intubated recently? Maybe something you guys don't ask routinely. Did you have recent surgery? Maybe you knew about it, but you're thinking the cervical spine surgery is related to this hoarseness, or the thyroid surgery, or the bypass surgery, thoracic surgery. So you have to think about recent surgeries, and they really want you to focus on that. Of course, lifestyle things, smoking, tobacco, bad diet, bad eating habits. I have so many young ladies and both teachers and waitresses in Old Town who, they're eating at 12 o'clock at night, they're sometimes smoking, and they're yelling at the top of their lungs, either the kids or the people in their bar. So there's a lifestyle problems. Do you have, if you have an older patient, do you have some other neurologic conditions that should be thought about right away? And I'll mention kind of briefly these, but Parkinson's, ALS, they have some very classic problems with the voice. And I feel those patients are going through enough. We shouldn't neglect that part for them. Psychiatric history, the medications. The medications can play a big role. They dry out the throat. And then there's some conversion disorders. And I'll talk a little bit about what they sound like. Endocrinopathies, hypothyroidism, and then, of course, cancers. And I think you guys will probably be looking for those things. So can any of these things kind of clue you in right off the bat? So what's a breathy voice? So I kind of went through that. The patient who, let me see if I can do it. He's really trying hard to get it out. And sometimes there's a little voice, but it's mostly just air escaping out of his throat. So that is probably a vocal cord paralysis or a very big lesion that's keeping the vocal cords from coming together at all. Certainly, the vocal cord paralysis is the one we see in our office. We literally walk in, and I'm like, they start talking, I'm like, 90% chance unilateral vocal cord paralysis. And I don't even tell them, and sometimes I try not to be cocky because they're still going through this. And I'm getting nerdy, but they're going through this. Vocal fatigue. So this doesn't mean tired. That's the dysphonia. That's being tired when you talk. This one is that your voice is fatiguing. It's kind of wearing out. So it can be a paralysis. It could just be atrophy. The vocal cords, as we get older, the vocal cords thin. Just like our skin starts to droop a little bit and our orbital rims start to show, so does our voice box go through those changes. And then neurogenic. And we'll go through that again a little bit when we get to the neurologic section. Choking, so think about CVA, especially in your older patient, some kind of stroke, vocal cord paralysis, things are going to get to slip through. Odynophonia, pain. There's something, either a muscle tension, they're straining so hard they actually get sore, just like you'd be working out, your arm will get sore, your voice gets sore. But also sometimes some lesions, the vocal cord granulomas, they can cause ear pain, and they can cause pain when you talk. And so sometimes these areas are a little tender, and they can cause contact irritation. Laryngospasm, I think more of laryngospasm with reflux. I get people who wake up in the middle of the night and they're like choking, and they've sought so much help, they're freaking out, and you put them on reflux medications, it all goes away, kind of verifying through empiric therapy that you're on the right track. But you got to think about nerve injuries, and we're looking for that. Stridor is one that most people don't miss. They sound really like they're struggling in the office. So that's one I think you'll immediately know this needs to be referred on very quickly. Vocal tremor. So that's Katharine Hepburn. On Golden Pond in a very rhythmic voice. So I don't think I did a good job, but you kind of get the picture on that one. VPI, this is a weird one because this has nothing to do with voice, but my myasthenia gravis patients will sometimes come in and they'll talk with the air coming out through their nose. And it sounds like a hoarseness, but their voice is okay. If you ask them to hum, it's sounds great, but you ask them to talk in their nose, everything's escaping out their nose. And then they'll go in and out of it and all of a sudden be talking normal, and you're like, okay, maybe this is a conversion disorder. And then you have globus. Globus in our office is reflux until proven otherwise. No, that's a bad joke. But if you've met an ALS patient, they will freak out about this feeling of mucus pooling in their throat. And they're more worried about that than the fasciculations and the tremors, or the fasciculations, I should say, and the weakness. So how are we going to describe this to each other? We have some scales, and you could memorize them, but I'm thinking by using these words, you're just going to start giving you things to use when you're talking to your patients. There is a scale called the Gribus. There's also the Cape 5, and those are things that we as physicians are supposed to use to each other. We still don't do it as much as often. We often describe it as raspy or breathy. We'll talk about a glottal fry, which is, that's the glottal fry. But the Gribus scale is so that we can talk to each other as ENTs, and we talk about the grade, we talk about the roughness. The rough voice is very, very raspy, and I can get good projection, but it just doesn't get any clearer. That's a really bad one, by the way. The breathiness we went through. Asthenia is that sense of power. And for asthenia and strain, I can tell you the opposite. So the opposite of the asthenic voice is the asthenic hoarseness. And that's the woman who has the conversion disorder. She comes in with a breathy voice, and she'll talk to you like this, and you're looking at her going, are you being for real right now? And she is. She is being for real right now. Hi, I'm talking to you like this. And we look down there, and the vocal cord's moving, and as Dan once told me, he goes, speech therapy, so she can think this one through. But there is something going on. This is a conversion, and not always is it for secondary gain, but there is some malingerers out there, and we pick this through, and I think we give them the chance to try to kind of delineate that problem with us. I never point a finger. I'm very good at kind of going around the back door to try to get them to realize that this isn't normal. And I say things like, gosh, your voice box is so normal. Then there is strain. Strain is our spasmodic dysphonia. And this is a cool one because this one you can make a big difference. And it's on the clinical practice guideline, which we'll get to at the end. Strain is that exuberant effort. And the best example of that is the patient with spasmodic dysphonia, and they will look like every ounce of their body is trying to get this voice out for you, and they are just really, they're very anxious to get it out. Like they're trying hard. These are not the underachievers. And so a classic one is, we eat eels every day. I'm trying very hard to get this voice out, but I can't seem to get it out as fast as I would like to. And so they're trying. And they have a problem with fluency, which we'll get into in just a second. So then there's pitch. You know, as we get older, the men's voices get higher, the women's voices get lower, and pretty much by about 90, we all sound the same. This is a bit true. So there is, but pitch, I feel like my voice is higher or lower than it typically is. Stability, it feels like it breaks up. Projection, I can't get that asthenia. I can't get that voice out. I feel like I'm struggling. You may not feel it, but I feel it. Diplophonia, this is This one, you get that, you can put it in the bank. There's a lesion on their vocal cord that probably needs to come out, may need some kind of therapy to see if it can get rid of itself. But I can't fake this one. It's 2 voices at once, and it's because the lesion is so big that the lesion vibrates and the vocal cord behind it vibrates, and 2 sounds come out of this voice box. You can hear it very clearly, and next time you hear someone with this, you'll remember I said that, and you'll say, oh, I heard it. Because it has passed you before. You have heard this person before. It's just you didn't know that that's what was going on. And then aphonia, and that's a tough one to work with. And then fluency, we'll get to in just a second. So we got neurologic disorders. We got something's wrong with the lining, that cover I talked about. We got something's wrong with the movement. I can't get the 2 wreaths together to make noise. We got inflammatory things that you guys deal with on a regular basis, and then we got cancer. So neurologic disorders. Let's jump down to this one really quick because I just want to get it off my plate. Parkinson's, this is our patient who's rigid, who has no expression or very little expression, and they just don't move their mouth hardly even, and they talk really soft, and you're kind of leaning in to hear them talk. It's a normal voice, but they're not giving you that projection you want, but they feel no urgency to do so. Or maybe they do, but they're not being able to comply. ALS patient, these are complex patients. And if you've seen them before, their tongue can have a bag of worms. They'll sit there and you're talking to them, their arms are fasciculating right in front of you. It's very alarming. And they're scared, and they know there's a problem. Myasthenia gravis can be very, very tricky. Most of the patients find out by the time they present with the classic things: droopy eyelid, diplopia in the morning, or as the day goes on, things fatigue and get worse and weaker. So they have classic things, but they do have this VPI that we have to deal with, and they can have some when they have their exacerbation. You gave them, was it Levaquin? I think that's one of the bad ones. I have a list in my office, so I have to look at it every time. You gave them the bad one, and they all of a sudden got really weak, and they're upset about it, and you remember never giving that medication again. Strokes, progressive supranuclear palsy is going to be kind of one of these things. It's going to kind of go together. But anyways, I have diagnosed a dozen times, maybe more, Parkinson's in my office, and they've never seen anybody else. And I'm like, how does it get this far? And it does. And so I always ask, I'm not a neurologist. I'm probably not very good at it, but I ask like some silly questions like, do you ever get tremors? Do you ever feel like you have a hard time getting started walking, or things just kind of shuffle along for you? And I pick up things. Do you have any problems swallowing? And we're hitting multiple systems, and it's just yes, 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 yes. I've got maybe a neurologic condition. Why couldn't that? It's just like when Dr. Mami was talking about congestive heart failure being a problem. You got to think about the other things. So these are, though, the things that are really neurologic disorders at the voice box. Spasmodic dysphonia is a focal dystonia. So they can have dystonias. In fact, 16% of them have like these little spasms in other spots of their body. Vocal tremor is Katharine Hepburn. Muscle tension dysphonia, there's probably been a problem with the voice box, and this person learned to strain. But they strain in a specific way, and I'll separate it in a second. But they strain, and then they stop. They never stop straining. They started talking like this. They can talk real fast, but they talk like this all the time. And they are just trying so hard. I got to get back to work, and they are usually pretty high energy about it. They're big talkers. And they have another underlying problem most likely, but they've learned this behavior, and then they have a hard time breaking it. And sometimes these 3 can occur in mixed patterns, and they can be hard to separate. And this one can separate into 3 different types. So 3 types: adductor, abductor, and mixed. So this is a spasm of the voice box in the truest sense. The adductor means it's spasming when it's shutting, the abductor when it's opening, and the mixed, a little bit of both. 87% are the adductor, and that is the we eat eels every day one. Real patient.
Yeah. You say we eat eels every day?
We eat eels every day.
Could you kind of hear? I know that wasn't probably the most projected, but she did it about, I think I did a pretty good job. She did it about like I did it. And so these patients, used to get laryngeal framework surgery. We used to try to expand their larynx. We used to go in and purposefully cut their recurrent laryngeal nerve so only one vocal cord was going to be doing spasming, I mean, when they were in the bad cases. So years of trying things, and then came along this little wrinkle injection called Botox and cured their world for about 90% of them in the adductor type. They last for 3 to 4 months. God forbid they become allergic to the Botox. There's another type, Dysport. But this is pretty much a life changer for these people. And there are some familial types. There's a thing called Hemorrhage syndrome where they have an oculopalatal dystonia. So they have dystonia in more than one part of their head and neck. But for the most part, it's usually at the larynx, and Botox is amazingly effective. We inject it into the thyroretinoid muscle directly. So the abductor type is a little tougher. It's not as successful with the injections, but it's still in that one. So the we eat eels every day, spasmodic dysphonia, it is a problem with spasm after voiced vowels. So E, that's why I use we eat eels every day. They spasm right after the E, and they're not fluent. So how do you separate these guys? They're not fluent. Fluency is the ability to continue on with the phonation in speech in a fluent pattern, like I am doing right now. But when they're spasming, they talk like this, and they get trouble trying to get the voice out, and they're straining to just continue their fluency. Whereas with the muscle tension that can sound like them, I talked about, they're just straining right along. They have no problem. No problem, doc. I can keep going if you want me to. So the spasmodic dysphonia, remember the vowels set them off, and it's very irregular, non-fluent, broken, and they're straining like crazy. And it's a real deal, and they can be fixed. Muscle tension, we talked about it. This is usually taken some time to happen. It did not occur overnight, and therefore it doesn't get rid of overnight. We have to give them voice therapy to relax their larynx. They do get some pain in their throat, and they'll actually start telling you their pain goes to their neck and their back. It's like they're straining here and everything gets affected. And when it goes away, they'll tell you that all the back and muscle pains went away. I don't want you to think you can cure all back and muscle pain with this. But the back and muscle pains go away, and as well, sometimes a feeling like there's something stuck there goes away as well. Here's a picture of a voice box. This is a fairly normal one. Here we got our white vocal cords, our false vocal folds. And here we have one, I'm looking at it, this guy's making a voice, and it looks like he's squeezing, right? It looks like it's squeezing together. The false vocal folds are almost meeting, and the arytenoids are crowding together. And look at this guy. He's trying to make a voice. It looks like he would be choking to death. And that's his posture when he's making a voice. So these people need to learn to relax their voice box. All right, so now we're getting into the stuff that sometimes requires surgery. These are the inflammatory, autoimmune, neoplastic, and traumatic mucosal disorders. The inflammatory will go through reflux laryngitis. We'll go through fungal. Viral is going to be during your acute viral syndrome. Certainly something that typically will last somewhere on the order of 3 to 5 days. And sometimes responds well to steroids, but again, we'll talk later, you have to be careful with steroids. Bacterial, this is supraglottitis or epiglottitis. I mean, they're going to the emergency room. They're sick. You know there's something wrong. This isn't a long-term voice disorder. Autoimmune. I won't go into this in a great deal. I think Wegener's always one that we like to talk about in length in ENT because it's interesting. It's now called granulomatosis with polyangiitis. It doesn't have the same name. And it is, if you have someone who presents with a idiopathic unknown cause of scarring of the subglottis, then it's most likely this, or maybe reflux, but usually this. Pemphigus, never seen it in the voice box, seen it in the mouth a few times. Relapsing polychondritis, this is going to be multiple cartilages involved, but it's in the differential. Sarcoid, less than 1% present this way, but they get this tubular epiglottis, and it looks like there's something just swollen and wrong with their larynx. And amyloidosis, that's a deposition of little minor proteins, and so you got like lymphoproliferatives, multiple myeloma, medullary carcinoma of the thyroid, and they deposit this stuff that's apple green birefringence on Congo red stain under phase microscopy, just in case you want to know that. But so these, you're going to be looking at probably some other systemic stuff. You're going to be able to figure this out, but it's in the picture. We'll get through some neoplastic, specifically recurrent respiratory, and then I'm going to go through some pictures of some stuff. So finally, some pictures. All right, so this is laryngopharyngeal reflux, and I think Dr. Hagen went through this earlier. We're looking at someone whose voice box is being irritated by the regurgitation of either acid or, maybe not acid, bile salts. And sometimes there's proteins in those bile salts, such as chymotrypsin and trypsin, that are reactivated in acidic environments that may be irritative as well. But they can get this it looks like pillows, right? A little billowy back here. And then this is we call this pachydermia, interarytenoid pachydermia. It looks kind of leathery. These vocal cords are definitely not those white strips. They're kind of swollen, billowy. There's little ectasias. And we like to talk about ventricle obliteration, but I say the word more than I actually see it. And you can kind of see some of these things over here. He's got the pachydermia, and the arytenoids aren't as big and billowy on this one. So I want to take a quick moment to mention that, reflux pills are all of a sudden, the demon out there. And your patients come in, they're like, I heard I'm going to get Alzheimer's, kidney disease, heart attacks, and low calcium, bone fractures, hypomagnesemia, and then if I take Plavix, I might bleed to death. And your answer is, yeah, maybe. And so I think we need to take them seriously. But that doesn't mean you throw the baby out with the bathwater. I mean, these drugs have also radically changed the quality of life of a bunch of people. And if you ever met someone who has a Nissen, they can't burp and they can't throw up ever again. That's a quality of life problem too. So there isn't always a right answer, and I'll take that in consideration. With that said, the standpoint of another one of those don't do's, the standpoint of the academy was, if you suspect laryngopharyngeal reflux, then they have to have an associated factor to confirm there's GERD before you treat. Now, that was their standpoint. Most of us do empiric treatment, but that was their standpoint. And that would include either esophagitis on scope, pH probe test was positive, or what we usually use is heartburn, right? You get heartburn, you're like, yeah, that's reflux. So what are their symptoms? They'll get a chronic postnasal drip sensation. Throat clearing is probably the one that we hear first and foremost. They will have some raspiness, usually worse in the morning, a lot more coughing in the morning, sometimes in the middle of the night. They'll get laryngospasms. They'll actually wake up choking in the middle of the night. And then, I'm probably missing another one. Oh, and the globus sensation, feeling like something stuck down there, like a foreign body is down there. And it does take longer for the reflux pills to work. The Academy originally, or the original studies all recommended BID high-dose therapy, 40 milligrams of omeprazole BID. Most of us do some kind of hybrid. Most of us maybe start out at 40 and try to titrate down and maybe add a Zantac at night. Don't keep them on that long term. Try to empirically confirm our diagnosis. But I do agree with trying to get them off lifestyle modifications, elevate their head of bed, cut down on the caffeine, carbonated, avoid the throat clearing. Sometimes just the process of that. If as a room we all just started clearing our throat and left, and a week later came back after clearing our throat for a week, we'd feel like something was stuck down there too, even without the reflux. Fungal laryngitis. You guys probably have prescribed Advair at some point in your careers. And this is what we see when they come in with a sore throat, raspy voice after being on Advair. Not every time, but it's a very good feeling because I get to point the finger somewhere other than my office. And diflucan does an amazing job, but only as long as they're going to be off of it. And so, they're on Advair and Brio and Dulera and all those different inhalers. And these things are caustic and sometimes injurious to the larynx, and certainly fungus can grow with some of the steroids. Vocal nodules, so this is the one that every singer kind of dreads, and they shouldn't really because most of them are probably going to get these at some point. And these are basically wear and tear areas of inflammation. So they develop at the junction between the anterior and the middle third, and they are at the highest vibratory point of the larynx. And so these people are using their voice. It's very common in young girls, like little girls, and then sometimes young women. I get a lot of teachers. Teachers suffer from this big time, where they're using their voice during times where their voice is weak or traumatic. And so they extend that vibratory period longer than it should be, and they get some hyalinization, and these little nodules form. And these are small ones right here. These are very small. I gave you two very small pictures. We've seen them bigger. It used to be 6 months reflux speech therapy. I'll see you in 6 months. And the new guidelines say No reflux therapy unless they got heartburn, a positive pH test, or esophagitis, although most of us probably obey that a fraction of the time. But speech therapy is definitely the way. This is the vocal misuse disorder, and it can be corrected. Just like if you were weightlifting and you got calluses and you stopped weightlifting for a while, it can be corrected. We just use our voice box so much, and they're out there working their tails off, and they can't stop. The kids just don't quiet down. 3 months, it used to be, I'm not going to touch you unless it's been a year as far as surgery. We can take these off after 3 months. I still would recommend very conservative thought. Julie Andrews had this done, and then she stopped being so prominent for a while. I don't know if there was any other challenges with that because I wasn't, deposed and involved in her court case or anything, but it was related to a situation like this, and so you have to be careful because scarring can occur, and so it is not just like you have vocal nodules, cut them off. Definitely the opposite, but we're probably almost too conservative now. Vocal cord cyst, this is actually one of my cases, and so this guy came in with Dysphonia, sole and alone, and I sent him to speech therapy, and I have to admit, I'm embarrassed to say, to check the box, because I knew this guy was going to need surgery. And as I read the clinical practice guidelines, I realized that they're actually encouraging that in certain situations, like a gross glottic insufficiency, so like a vocal cord that's paralyzed, or in a large lesion that is causing glottic incompetence. Certain situations, it's like, yeah, that looks like it needs to be cut out. There are times to cut it out. So in this particular instance, I had this very large lesion. I've actually pushed on it. So it used to kind of go like this, but I pushed on it so you could see it better. And then I made an incision over here called the microflap technique. And then I dissected for 35 minutes with a little tiny spatula like a pinhead, going like this for 35 minutes around this thing until it was really well isolated, made an incision superiorly and inferiorly in the soft tissue, and this thing starts to pop out. The goal here is to keep this lining intact, which I did. You can see a straight edge here. You can see it's kind of mottled because like a balloon, it had just been stretched for so long. I think when it deflates, it had this like pachydermic lesion. But he came out of the OR sounding, I was meeting a new guy. He had a perfect voice at the end of it. These are vocal cord granulomas. We see this all the time after intubations, but we also see it sometimes on people spontaneously. And we think reflux plays a big role. In an intubation, the endotracheal tube lays right here. It pushes on that, and then they're like asleep for like 3 hours, right? And so no wonder they get a little ulcer there. If you ever got an ulcer in your mouth, you can imagine how pressing on that for 3 hours could do that. And then the body is trying to heal, but they keep smacking those areas together, and they're just smacking it together and together, and maybe they have some reflux, and this hyperplastic tissue that's not cancer called granulation tissue develops. We like to treat this with speech therapy and potentially reflux therapy. Probably a higher percentage of reflux therapy is used in this scenario with speech therapy. If it gets big and it's blocking the whole area, we'll cut it off, but you don't want to cut all of it off because it'll just come back. So you literally leave a little rim of the tissue there and let it kind of heal on its own. This is our vocal performers, vocal hemorrhages. So vocal performers, we give them a list of stuff not to take. Don't take antihistamines, don't take beta blockers, don't take blood thinners, don't take aspirin. Stay away from all your depression meds because it's drying your throat. And all these meds can dry out the voice box and irritate the larynx, and then they're using it a lot. And they'll get these blood vessels called varix or ectasias, and these can expand. And then if they're on some aspirin or they really belt it, and it ruptures, and then they get a little hemorrhage, and that hemorrhage will then organize into a cyst called a vocal polyp or a hemorrhagic polyp. And we try to let these go away with speech therapy. Sometimes they have to be cut off. Recurrent respiratory papillomatosis. There's juvenile and adult. Adult tends to be more focal. Juvenile can be horrific. It can spread into the actual airways, down into the lungs. It could potentially kill children. They are very rapidly regenerative, and it's due to the HPV 6 and 11 virus, not so much the 16 or 18s. And it occurs here because this is a junction between respiratory and squamous epithelium. And so that junction seems to be a susceptibility to the virus. They look like cauliflower down there. We take these off with cold knife, or we can laser them. We like the KTP sometimes because it follows blood vessels with the hemoglobin affinity. But a lot of people use CO2 because it's a superficial burn. CO2 doesn't go past water, and everything's made out of water, so it just stops where it hits. But you still have to be very careful because the goal of surgery on this is to not hurt anything. So you're not in there like, I'm going to clear this thing clean. You're in there to say, I'm going to try to get everything I can grossly, but I want to leave all the normal stuff untouched. There are some alternate therapies. Cidofovir was getting really popular. Now it's Avastin. Cidofovir is an antiviral that we would inject, but it caused a few rats to get tumors in their back, so they're not really excited about that. It's really good if they're getting like 5 episodes of this recurring a year. And we can inject it with Avastin, which it discourages blood vessels from forming, and this little bugger likes to follow blood vessels, real big. There is a fiber optic in the office treatments, and they do it at like UC Davis. There's a guy in town who does it, who I'm fond of. Most of us don't do it because the laser is expensive. And you don't have these guys walk in and off the street every day, and so there are not enough of them to support in-office treatment, but that may get better as time goes on. Vocal cord paralysis, I talked about my lady. Whenever you see a vocal cord paralysis, you have to think, is there something growing in the chest or in the thyroid gland that's causing that nerve to not work? We can actually help this, though. We can push that vocal cord back over in the middle so that the other one can work. And we do that by injecting some gel. One's called Prolarin. It's a carboxymethylcellulose gel. And then there's a longer-acting one, hydroxyapatite. That's the one that Radiesse use in ladies' wrinkles. And so these can plump up that vocal cord and give them their voice back. So you have somebody who maybe was intubated and then their voice stopped working and maybe it'll recover. We can actually do something to make their voice better until they recover. How am I doing on time? Oh, we're still good. And then don't forget the workup of the recurrent laryngeal nerve. These people have that breathy voice. Everything seems to just slip out. They literally get short of breath because they feel like all the air gets out before they get to get their words out. And they'll choke sometimes. And interestingly, when they choke on liquids, you tell them whatever side their vocal cord is paralyzed on, you tell them to turn to that side, and then they'll swallow much better. It's a dramatic change for them. But, it's kind of annoying to swallow like this all day long. Cancer. So this is what we're looking for. We don't want to miss this. It starts out as a white lesion called leukoplakia, which just means white plaque. And then it becomes hypertrophic. Sometimes it stays in leukoplakia for a while, and somewhere between 8 and 18% convert into cancer. But we don't like that white lesion, and we will take that off most of the time, even when we don't know if it's cancer yet. When it looks like this, then you're just taking a big biopsy of it and then finding out the diagnosis and deciding what you want to do. This person could have options of resecting it transorally. They could have an option of removing the whole larynx if there's other lymph nodes and other concerns, or the vocal cord's fixed. This person could go through chemoradiation therapy and may fix the larynx, but we got to make the diagnosis first, and I don't want to go into the workup of that right now because a little bit more than we have time. So the clinical practice guidelines, what did they tell us? Well, they said, listen to your patients. Tell them, when they tell you have hoarseness, you can put them off for a week or two. I mean, nothing goes that bad in a week, right? But if they keep coming back and they sense this urgency and you don't sense it, there's something. I try to believe my patients more than not. Assess the factors. They really hit hard on surgery, previous head and neck cancer. Did they have radiation to their neck? Is there something going on there? Were they intubated recently? Are they smokers? Are they at risk? And then have they done something traumatically that puts them at higher risk? Here's a big one. I didn't go into this yet. Laryngoscopy is recommended. It's recommended after 3 months of hoarseness, and I'm going to tell you after 1 month. Because the earlier we intervene, the better. And more importantly, a lot of the treatments that we'll talk about with these patients include speech therapy, having them work through and help their voice. But the recommendations very solidly said, no speech, primary evaluation, it's on the next page. No speech therapy before a look has been done at their vocal cords. And a lot of the speech therapists will send them back to us and say, you know what, I'm seeing this patient for the Lee Silverman Big and Loud program for Parkinson's, but will you look at their voice box first, make sure I'm allowed to go ahead and do that, okay? No imaging. A hoarse voice needs to be looked at first. No imaging to start. I mean, if they have a big lump in their neck, use your common sense. But if it's just hoarseness and you're not finding something else, then no imaging. Reflux medications should only be tried on patients with signs and symptoms confirmatory for reflux. I'd say most of us probably are a little bit outside of our own clinical practice guidelines on that. But I think it's a good reminder at how important it is to think about those reflux meds. Steroid therapy. So the most common treatments by primary care when they looked at this meta-analysis was antibiotics, 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 antibiotics. Most common treatments by ENT was reflux therapy, and some steroids, maybe inhaled, maybe oral. So, you know, the world's a nail. I mean, you have a hammer, the world's a nail, right? You know, and I would just say that maybe we can kind of forego some of those steps, at least after you've tried it once, to go on and take a look at the voice box. Steroids should not be routinely used. We recommend in vocal professionals, sometimes we'll give them steroids as long as we don't think they have a severe laryngitis or a hemorrhage or something. We'll give them that and a voice rest to try to get them over so that maybe in a week or two they can make their next best performance. And certainly in acute laryngitis, it can get them over faster. But recurrent steroids have some downsides. All the ones that Ryan talked about before, necrosis of the hips, cataracts, high blood pressure, high blood sugars, ulcers in the stomach, and I can go on and on and on. But it also is thinning, and it thins the vocal cords to some degree, and they're overusing. So don't get the patient who loves you once because you gave them steroids, and you decide, I'm a hammer and the world's a nail. You just don't want to keep using steroids. Maybe once, every now and then, but watch their steroid use. Look at your chart and see how many times have we done this before we ever do this again. And certainly, if that hoarseness lasts more than a month, or you do feel like it's frequent, please send them on because I think they need to be looked at. Surgery is advocated. Well, clearly for malignancy, I think this is a kind of a simple category, but glottic insufficiency, and that was really referring to the vocal cord paralysis. There's no speech therapy for vocal cord paralysis. Get that vocal cord over and inject them. You don't even need to see a speech therapist. And then soft tissue lesions like that thing I showed you that I removed. Botox. This is just a game changer. Just remember that weirdly paced, non-fluent voice that's straining beyond belief, give them Botox. Get them to a laryngologist who can do it. And then preventative measures. Always talk to them about their lifestyle. Look for the systemic diseases, and I think you'll do your patients a service. I think I've kind of covered most of this. Early evaluation more than later. I say 1 month, they say 3 months. Certainly somewhere in between. You can grade the severity. Antibiotics, be judicious. Be selective. Purulence would be a good reason. Steroids, just not frequent. Voice therapy only after a scope. Thank you.